Okay, sir. Shashi, sir, it's sharp 11. Shall we begin?
Yes, sure.
Shall we wait for a few more participants?
Up to you. Up to you.
We wait for 5 more minutes, sir, and then begin.
Okay, fine.
Shall we start, sir? We have switched on the YouTube live.
Sure.
Okay. Good morning, everyone. We welcome you all for the second day of Virtual Pathology Week CME. On the second day session of Virtual Pathology Week, we have a first session by Dr. Shashikumar Attili. We welcome you, sir. Dr. Shashikiran Attili is a trained dermatopathologist and has worked in UK for more than 10 years. He has done his MRCP in dermatology and then fellowship in dermatopathology in UK. He also has an additional qualification of ICDP, International Diploma in Dermatopathology, Frankfurt, as an extra feather in his hand. He has more than 25 publications in various international peer-reviewed journals. He's also an editor in IJDBL. He has won Best Speaker Awards at various conferences. Today, he is with us to share his expertise knowledge on approach to lichenoid dermatitis. Sir, the session is all yours.
Thank you very much for the invite, Dr. Venkat, and I thank the organizers for inviting me and allowing me to speak on one of the favorite topics of mine, which is interface dermatosis or lichenoid dermatitis, as most people are familiar with. So, I will first try to clarify the basic misconception or the confusion between interface and lichenoid dermatitis. Now, this is a very confusing topic. What is interface dermatitis? What is lichenoid dermatitis? What is vacuolar dermatitis? So these are all used interchangeably by a number of authors, and this can be quite confusing to a novice. Well, what is interface? Interface basically refers to the junction between the epidermis and dermis, and this extends down the adnexia, down the follicular units. It extends down the eccrine glands as well. So the dermo-epidermal junction at the level of the skin at the epidermis and along the adnexia, the entire area is called the interface. Okay, so any dermatitis, any inflammatory condition affecting this particular interface is called an interface dermatitis. All right. So interface dermatitis can be of two types. One is a lichenoid interface dermatitis type, and there is a vacuolar interface dermatitis. Now, how do they differ between each other? Well, lichenoid traditionally refers to an inflammatory dermatoses which are characterized by a band-like lymphohistiocytic infiltrate, often hugging and often obscuring the dermo-epidermal interface. So the classical example being lichen planus. So this is what we mean by lichenoid. And this is the prototype. You see a band-like infiltrate just below the dermo-epidermal interface. Okay, it's not obscuring in this case. There are a few other obscuring conditions, and this is an example of that. This is a case of erythema multiforme, where the lichenoid infiltrate is obscured and actually destroyed the epidermis. The epidermis has become necrosed here. So this is quite a florid case of drug-induced EM, and you can see here that the epidermal interface is completely obscured. You can't see the basement membrane or the basal epidermal cells. All right. So how does this differ from vacuolar alteration or vacuolar interface dermatitis? Now, vacuolar alteration traditionally refers to the presence of vacuoles along the dermo-epidermal interface, and these vacuoles could be above or below the basement membrane or even within the basement membrane. I'll explain that in a second. All right. So this is an example of what we call vacuolar interface dermatitis, wherein you have vacuoles within the basal epidermal cells or below the basement membrane also in some cases. Now, so vacuolar alteration therefore refers to tiny spaces on either side of the basement membrane, often associated not with a band-like infiltrate, but just a sparse sprinkling of lymphocytes in the papillary dermis. A confluence of such vacuoles eventually leads to the formation of Max Joseph spaces or subepidermal blistering, as we call it in cases of LS, lichen sclerosis, lichen planus, and EM, erythema multiforme. However, having said that, vacuolar alteration is also seen in the so-called lichenoid dermatoses. So, vacuolar alteration is not restricted to vacuolar interface dermatoses. Vacuolar alteration is present in both. So this is an example of lichen planus, and in lichen planus you can see the sawtooth retiridge, and you're seeing vacuolar alteration. So vacuolar alteration per se does not give you a diagnosis or does not differentiate. The main difference between vacuolar and lichenoid is lichenoid infiltrate is basically a band-like infiltrate which is cell-rich. If it is cell-poor, now both have vacuoles. If it is cell-poor, we call it vacuolar, and if it's cell-rich, it's called lichenoid. That is the basic difference, and it is not a very hard differentiating factor, and I'll explain this as we go along. So basically, interface dermatitis is inflammatory dermatosis primarily affecting the interface. Lichenoid being where the interface dermatitis has, there is intense inflammation overrunning the vacuolar interface change, so you're not able to see the vacuolar interface change on low power. In vacuolar interface dermatitis, there is a paucicellular interface dermatitis, and because the inflammation is not so much, you're able to see the basal cell vacuolization as being prominent. All right, so that is a basic difference. The prototypes of lichenoid interface dermatitis, i.e. cell-rich interface dermatitis, are lichen planus, lichen nidus, striatus, and pityriasis lichenoides. The prototypes of vacuolar interface dermatitis traditionally are erythema multiforme, lupus, dermatomyositis, lichen sclerosis, and poikilodermis. All right. Having said that, as I mentioned repeatedly, the differentiation is not so clear-cut. A lot of so-called vacuolar interface dermatoses, eventually in the early stages, they can be cell-rich, wherein the inflammation is quite profound. And the so-called lichenoid interface dermatoses in the later stages, especially if you've treated them, they can become cell-poor. And this is an example of late-stage lichen planus with epidermal atrophy. And there is no lichenoid infiltrate here, just seeing basal cell epidermal damage. And this is not really a lichenoid dermatitis at this stage. This is an example of erythema multiforme in the acute stage where the inflammation is lichenoid. It is band-like. And here it is obscuring the dermo-epidermal interface. Okay. So though traditionally there is a classification, the classification has to be taken with a pinch of salt, and it only implies that that particular lesion is either cell-rich or cell-poor. So in my sign-outs, I usually tend to say whether it's an interface dermatitis or not. The term lichenoid and vacuolar do not really mean anything unless you actually know it's a case of lichen planus and you know that the clinician only understands lichenoid, and therefore I call it lichenoid for that reason. But for purely on theoretical understanding basis, all of them are interface dermatoses, either cell-rich or cell-poor. All right. So what is the pathognomonic sign of interface dermatosis? What is common to all interface dermatoses, whether they are cell-rich or cell-poor? The common pathognomonic feature is epidermal basal cell damage leading to cell death. And that is the most important feature that distinguishes interface dermatosis from other dermatoses. All right. And this is the classical example you're seeing here. These are apoptotic keratinocytes, dyskeratotic cells, as people know them as Civatte cells or colloid bodies. So this is the basic pathognomonic feature. Now, there are two types of epidermal basal cell degeneration, and you won't read these two types very often in textbooks, but I think it is important to remember because we are trying to differentiate the so-called lichenoid from vacuolar interface dermatoses. What are the two types? The first type of degeneration in the epidermal basal cells is the vacuolar hydropic, ballooning, or liquefactive degeneration. All these are synonyms. Okay. Now, by vacuolar degeneration, I mean, this is basically seen in both types of interface dermatoses. It's seen in both lichenoid and vacuolar. Here, the keratinocytes appear swollen due to intracellular edema, and this leads to formation of intracytoplasmic vacuoles. And the nuclei of such cells eventually become pycnotic, small, rounded, abnormal shape, spindle shape, and eventually undergo karyorrhexis, and the nucleus is destroyed. And this is a typical example. You can see here, the cells have developed intracytoplasmic vacuoles, and the nucleus has become hyperchromatic, pycnotic, pushed towards one side. So this is an example of a vacuolar or hydropic degeneration. Okay. Now, here's a first quiz. So we'll be having a few questions as we go along, and Dr. Venkat is kindly going to moderate them for us. So if you know the answer to this, please type it in the chat box, and Dr. Venkat is going to let me know which is the first right answer maybe. So the following are true regarding Max-Joseph spaces. One, they are only seen in lichen planus. Now, there could be multiple answers. The spaces are actually artifacts consequent to shrinkage of tissue during fixation and processing. The Max-Joseph spaces can be seen in lichen sclerosis, and Max-Joseph spaces can be either suprabasal, intrabasal, or infrabasal. So which of these is true? Please type your answers in the chat box. Which of these is true? There could be multiple answers. So we'll probably give another 5 seconds. Please type your answers. Which of the following are true? Okay. Dr. Venkat, there are basically three true answers. The true answers being 2, 3, and 4. So I don't know how many, are there any answers in the chat box?
Yes, sir. One of them has answer 2, 3, 4. Others have answered 2, 4.
Excellent. Okay. So it's not only lichen planus, any interface dermatosis can have Max-Joseph spaces. And the spaces are actually artifacts. They can also be seen lichen sclerosis, and I've explained in the vacuolar interface change, they can either be supra, intra, or infrabasal. So now, when they become supra, intra, or infrabasal, they can be pseudo-vacuoles rather than true vacuoles. So vacuolar degeneration of the epidermal basal cells may not always be the only feature. You may have suprabasal vacuoles when the apoptotic cells get detached from the basal membrane. So these vacuoles you're seeing are actually between the cell membrane and the basal membrane. Okay, so these are pseudo-vacuoles seen suprabasally. Within the basal membrane, when the basal membrane itself becomes fragmented, you may see vacuoles within the basal membrane. So these are intrabasal vacuoles. And then infrabasal are artifactual vacuoles due to separation of the basal membrane from the scarred papillary dermis. And you can see here, this is the case of lichen sclerosis, and you're seeing here that the scarred dermis is separated from the epidermis by an artifact. This is due to processing artifact, basically. All right. So these are pseudo-vacuoles rather than true epidermal basal cell degeneration. And this is an example for Max-Joseph space, as you all know. And Max-Joseph space typically is seen in lichen planus. And now, this is question number 2. And you can again choose more than one answer. The following points can help differentiate artifactual clefts, okay, from true blisters seen in bullous interface dermatoses like bullous SLE, etc. Okay, so there are true clefts and there are artifactual clefts. There are true bullae and artifactual bullae. So one, artifactual clefts do not contain serum. So choose more than one. You can choose more than one answer. More than one of these is right. Acantholysis is seen in true blisters. True blisters contain inflammatory cells. Presence of epidermal spongiosis suggests that the blister is not artifactual. So again, type your answers, please. We'll see who gives the right answer. So if artifactual clefts do not contain serum, if that is true, then put your type number 1. Acantholysis is seen in true blisters. Artifactual clefts may not contain acantholysis. This is a trick question. So only type 2 if you know that acantholysis is seen in all true blisters. Number 3, true blisters contain inflammatory cells, true or false. Then presence of epidermal spongiosis suggests that the blister is not artifactual. So if you're seeing a blister there and there is epidermal spongiosis, then the blister is likely to be a true blister. Okay, so the right answer is artifactual clefts do not contain serum and they do not contain inflammatory cells. So if they contain inflammatory cells, it's a true blister. Okay, so 1 and 3 are the right answers. Acantholysis is not necessarily seen in true blisters. It can be seen, it may not be seen in true blisters also. So I know that's a trick question, but the right answer is 1 and 3. Anybody with the right answers, Dr. Venkat?
Actually, 1, 3, 4, they have answered, sir.
4, yes. Epidermal spongiosis does not necessarily suggest that the blister is not artifactual, because epidermal spongiosis can be there even in inflammatory, even in, for example, in inflammatory lichen planus, you can have, when there's a lot of excoriation and scratching, they can have reactive spongiosis. So that does not necessarily mean that the blister is a true blister. Okay. So now this is a textbook example of bullous lichen planus. Is this a true blister or is this a artifactual blister? Type 2 true for type T for true, F for false. Please type your answer in the chat box. T for true, F for false. This is a textbook example of bullous LP. So you need to know whether in bullous LP, the blister we are actually seeing is a true blister or an artifactual blister. Type T for true, F for false. We give another 5 seconds. All right, Dr. Venkat, what is the majority opinion?
False. Majority of them have answered false, sir.
Excellent. That's quite right, actually. The bullae in bullous LP are actually artifactual blisters, they're not true blisters. And as I've explained already, and most of you have already, most of you are listening, the blisters are actually an artifact due to the processing. They're not clinically visible. If in the case of LP, where you have clinically visible bullae, those are actually case of LP pemphigoides, lichen planus pemphigoides, and they do contain serum. The actual bullous, so-called case of bullous LP are more of a histological diagnosis than a clinical diagnosis. And histologically, they're also not true blisters. They're artifacts created by processing because the max dorsal spaces just join together. The vacuoles join together, and in processing, they just separate apart, the epidermis and the dermis. Okay, good. Dr. Venkat, if anybody is typing questions as we go along, you can feel free to interrupt me every 5 questions or so that I can go back to the slides and answer rather than doing it at the end.
Yeah, sure. So far, I didn't receive any questions. If so, I'll let you know.
Sure. So there are 2 types of epidermal basal cell degeneration. We've explained one type. One is a vacuolar type. There is a second type called the filamentous type. And this we all know about, but we haven't quite read about in textbooks, or it's not described in textbooks so much as, in so much detail. So filamentous degeneration is seen primarily in the lichenoid group of diseases, visible as shrunken diskeratotic keratinocytes. Now, what is diskeratosis? First of all, you have to understand what is keratosis. Keratosis refers to the maturation of the epidermal base of the basal keratinocytes. As they go up, they become keratinized. So as they become keratinized, they acquire keratin, and the nucleus becomes shrunken. Eventually, it becomes flat, spindle-shaped, and then it is in the stratum corneum, the cells lose their nuclei completely. This is the process of natural maturation. In fact, funnily enough, maturation in epidermis means death of the cell, because as the cell matures, it dies. So maturation refers to death. So diskeratosis refers to premature death, premature keratinization, and that, or dysmaturation. And what I mean by that, in dysmaturation, the keratinocytes, instead of acquiring keratin as they go up, the cytoplasm becomes eosinophilic and condensed and becomes keratinocytes as they, in the basal layers itself. And then the nucleus becomes small, shrunken, pycnotic, and gets extruded there itself. So this is what we refer to as disc keratosis. And these disc keratotic cells are visible here as Civatte cells, as we know them. They have an eosinophilic condensed cytoplasm, and this also has a vacuole around it. And it also has a pycnotic hyperchromatic nucleus. So this is a Civatte cell. So what is the difference between a Civatte cell and a colloid body? If you look at textbooks, a lot of them actually refer to them as synonyms, but actually they're not quite synonyms. And I tend to, I like to differentiate between them. When you're talking about a cell, you want to see a nucleus, all right? So Civatte cell is basically a disc keratotic cell with eosinophilic condensed cytoplasm, and the nucleus is still retained, like in the example I've shown you. When the pycnotic nuclear remnant is eventually, destroyed and it extruded out, these eosinophilic cytoplasmic globules then drop down into the dermis, in the papillary dermis, and that's when we call them Civatte bodies or colloid bodies or hyaline globules or hyaline bodies. So hyaline globules or bodies are what I refer to as these pink globules that are present in the papillary dermis once the cells have become destroyed and the eosinophilic cytoplasm drops down into the papillary dermis. Now, you might wonder, what is the difference between this and cutaneous amyloid? Cutaneous amyloidosis is also the eosinophilic pink globules are found by destruction of the epidermal keratinocytes. So in fact, both are the same. In fact, there was this electron microscopic study was done way back in the 1970s. And they have shown, there's a paper by, I can't remember the author now, I should have referenced it here for my own memory. But they have researched it and they have proven that these colloid bodies are precursors to the development of cutaneous amyloid. So they are a type of amyloidosis. And this is the example of a colloid body in the papillary dermis. So this is the basal membrane which is destroyed here totally, and then the colloid bodies have dropped down. Okay. So these are colloid bodies, and this is probably a Civatte cell because the nucleus is still retained here. All right. So what is the main difference then between lichenoid and vacuolar interface dermatoses? First of all, as I said, there's not much of a difference. But having said that, the so-called filamentous degeneration or dismaturation is usually seen in the cell-rich interface dermatoses. Okay, though both may exhibit vacuolar degeneration, this dismaturation is usually absent in purely vacuolar interface dermatosis, particularly in the dermatoses which have mild inflammation. For example, if you take vitiligo, inflammatory vitiligo has very focal, sparse interface infiltrates, and you don't see colloid bodies or these don't see. Colloid bodies are usually traditionally seen only in the cell-rich interface dermatosis. Maybe once the cellular inflammation is intense, it leads to premature death of these basal epidermal keratinocytes, and the cytotoxicity is so much it causes these colloid body formation. That's the main difference. But as I said, there is so much overlap between them, so it's really pointless looking for differences. All right, this takes me to the next point in discussing the basic pathology, which is high apoptotic keratinocytes. We've all heard of this term, and probably we haven't seen enough cases to understand what it means, and it took me a while for me to figure out what it means. So high apoptotic keratinocytes refers to these apoptotic keratinocytes which are not just in the basal layer, but also present in the upper layers of the epidermis. So these are called high apoptotic keratinocytes. So what does it signify? It signifies a cytotoxic T cell response. When the cytotoxins are so much, they percolate up into the higher layers of the epidermis, causing epidermal cell damage even in the higher layers. The epidermal cell damage is not restricted to the basal layers. So these acute cytotoxic type of interface dermatoses were sort of defined by Leboy in the late 1900s, and the examples of these being viral exanthems, morbilliform drug eruptions, acute GVHD, the erythema multiforme TEN spectrum, acute lupus, pityriasis lichenoides, usually the acute variant, fixed stroke eruption, and paraneoplastic pemphigus. Having said that, high apoptotic keratinocytes are also seen in phototoxic reactions, early onset Still's disease, and acrokeratosis paraneoplastica. Okay, now this also brings me to the next point when we're talking about apoptotic keratinocytes. This particular feature is referred to as satellite cell necrosis. Again, this is now an obsolete term. Satellite cell necrosis refers to an apoptotic keratinocyte being surrounded by small lymphocytes. So when small lymphocytes attach themselves to a apoptotic keratinocytes, this is called satellite cell necrosis. But though it was supposed to be specific for GVHD and the case of erythema multiforme, etc., nowadays we know that it is no longer specific and we don't usually use this term. But since this is a basic lecture, I thought I'll explain that. So this is a case, I think, typical. I hope all of you can make a diagnosis even without me going through the next of the lecture. So this is an interface dermatosis where there is confluent epidermal cell necrosis. The clue here to this being an acute disease is the presence of basket weave hyperkeratosis. Anybody know the answer, know the diagnosis? Please type it in the chat box. The first answer, Dr. Venkat, please let me know. What is the diagnosis when you see massive epidermal necrosis in association with basket weave hyperkeratosis? Anybody has typed an answer, Dr. Venkat? Hello? Hello?
Sir, actually, Venkat has got some power connection.
Oh, I see. Okay,
so some of them have written in the chat, toxic epidermolysis necrosis.
Okay. Yes. So this is definitely the TEN erythema multiforme spectrum. This is a case of erythema multiforme. And the typical clue is that in the presence of epidermal necrosis, if you're seeing basket weave means the epidermal keratinocytes have not, it's just an acute reaction. Therefore, you're still seeing the basket weave pattern. In chronic dermatoses of any description, generally the epidermis, the keratinocytes, the stratum corneum either becomes compact or it develops parakeratosis. So if you're seeing orthokeratosis, means it's an acute reaction. This is erythema multiforme. And often erythema multiforme note the associated ballooning degeneration. Okay? This is called ballooning degeneration, where the vacuolar alteration in cytoplasm so much they become balloon-like. Okay. So here's the next question. Madam, if you can maybe please let me know the answers in the chat box.
Yes, sir, sure.
Which of the following statements is false? Number one, ballooning degeneration is also seen in spongiotic dermatosis. If it is false, type 1. Ballooning degeneration is always accompanied by epidermal basal cell damage or vacuolation. If it is false, type 2. Ballooning degeneration is due to intracellular edema vacuolation. If it is false, type 3. There's only one false answer, by the way. Severe ballooning degeneration leads to reticular alteration. You need to know what reticular alteration is for this. So if there's only one false answer, please type it if you know the answer. Give another 3-4 seconds.
We got a few responses saying yes, 2 as the answer, sir.
2, yes, indeed, yes. So ballooning degeneration is definitely seen in spongiotic dermatosis. It's due to intracellular edema, and severe ballooning degeneration leads to reticular alteration. You're quite right. So reticular alteration refers to this feathery appearance in severe ballooning degeneration. This feathery appearance, wire-like appearance of the epidermis is called reticular alteration for people who don't know it. Okay, right. So how do I evaluate interface dermatosis? Now, there are 2 ways in which I evaluate interface dermatosis. One is I look at the primary features, and the primary feature, as I've explained earlier, is epidermal basal cell damage. Okay. Now, what about the secondary features? So we need to look at the secondary features, and that is how we come to a diagnosis. Now, before I go into these, there's one more quiz. In an atypical psoriasiform dermatosis or dermatitis, where there is difficulty in making a diagnosis, one can safely rule out the diagnosis of psoriasis if focal vacuolar basal degeneration is seen. Please type true if the statement is true, please type, or please type T if the statement is true, please type F if the statement is false. I'll read it out again. In an atypical psoriasiform dermatitis, where there is difficulty in making a diagnosis, you're not sure whether it's even psoriasis or not. If you're seeing focal, vacuolar, basal cell degeneration, you can rule out psoriasis.
We have got 3 responses. Among that, 2 are saying false and 1 has written true.
Right. Okay. So false is the correct answer. You cannot rule out the diagnosis of psoriasis just on the presence of focal basal cell degeneration. And there is a case series, in fact, of 51 cases where they saw case of classical psoriasis and they found junctional vacuolar alteration in 76% of cases, spongios in 76%, necrotic keratinocytes in 67%, and lichenoid infiltrate in 25% actually. So the mere presence of focal vacuolar alteration or epidermal keratinocyte necrosis itself does not mean it's an interface dermatitis. So make sure that the basal cell damage is primary. Incidental interface dermatitis due to antigen masking may occur in any dermatoses, including spongiotic eczema. So just because you find focal basal cell damage, so it should be the predominant feature. Unless it's a predominant feature, don't classify it as an interface dermatitis. Okay. Now the secondary features we evaluate are the epidermal changes, base membrane changes, dermal changes, and the panicular changes. And these give us a clue to the final diagnosis. Okay. So what are the determining factors of these changes? The determining factors of these changes are, 1, the intensity of the inflammation, whether it's lichenoid or vacuolar inflammation. The primary immunological targets, it can be the basal keratinocyte in the epidermis. It can be keratinocyte in the follicular unit, like in lichen planopilaris. It can be the acrine duct, like in lichen planoporitis. It can be the melanocyte, as in vitiligo. So the primary immunological target determines the pathogenesis. The rate of onset and progress of disease, if it's an acute disease, that determines the features you're seeing. If it's a chronic disease, if it's evolving rapidly, that determines the features you're seeing. And also whether the lesion has been treated or not, that also determines it. Time of biopsy, stage in the evolution of disease process. Definitely, these are very important factors. So even within the same patient, if you're taking biopsies from 2 different lesions, and in fact, even if you take a biopsy from 2 areas within the same lesion, you'll see different features, believe me. And then effects of special site may affect the pathological features. For example, photoexposed sites in LE, scalp and lichen planopilaris, acral areas usually leads to hypertrophic lichen planus, genital mucosal lesions, then you're dealing with lichen sclerosis. So these again affect the pathological features. Now, the way I was taught, you basically evaluate any slide from low power to high power. And that is the way I was taught, and this is what I am going to explain here. So in low power, there are 2 things which you can easily see. Is it a lichenoid or a vacuolar interface dermatitis? Is it a paucicellular or a polycellular infiltrate? Then the distribution of infiltrate. These 2 are easily visible on low power. Now, for example, if the infiltrate is confined to 1 ready peg, this is easily visible even on low power. This is a case of lichenitis. I'm sure all of you know. If the infiltrate is predominantly restricted to the follicular units, a case of lichen planopilaris. Okay, so this is visible on low power. So the distribution of inflammation, if it's superficial, focal, restricted to a single papilla, superficial pan section, like in lichen planus, dermatomyositis, erythema multiforme, superficial and deep, like in lupus, drugs. Is it superficial and deep and wedge shape, like in pityriasis lichenoides? Now, please note, I'll probably mention this here. In my talk, throughout my talk, I do not use the terms PLEVA or PLC, i.e. pityriasis lichenoides acuta or pityriasis lichenoides chronica. And the reason being, these distinctions are only clinical, they're not histological. Histologically, even cases of pityriasis lichenoides acuta, if you take the biopsy in a later stage, may show chronic features. Pityriasis lichenoides chronica, you take the biopsy in the early stage, it will show acute features. So please do not try to make the distinction histologically, it's not possible. All right. So then we come to superficial and deep with panicular involvement. If it's septal, then you think of morphia. If it's lobular, you think of lupus. And then periadnexal we've already talked about. And one important thing to remember, if you're dealing with a lichenoid infiltrate, which is also periadnexal, then think of lichen striatus. Apart from lichen planopilaris predominantly affects the follicular units. Striatus also affects the acrine glands. That's why I said periadnexal rather than just perifollicular. Okay. So going to higher part, what are the features in the epidermis that we evaluate when we're looking at the higher part? Now, this is also visible in low power, in fact, but yes, high power epidermal evaluation involves looking at the epidermal thickness, the first thing. This is a classical case of lichen sclerosis. There's no doubt, I'm sure, in most of your minds. Epidermal atrophy is a predominant or a classical feature in lichen sclerosis, atrophicus as it used to be called because of the atrophy present. And then hypertrophy of the epidermis. Again, this can be seen in low power as well. And this is a feature of lichen planus hypertrophicus usually. So as in the name implies, hypertrophy of the epidermis seen in lichen planus hypertrophicus. And I probably should mention classical lichen planus at this juncture itself. So classical lichen planus is a case where you're seeing classical sawtoothing of the retiridges, hypergranulosis. The so-called wedge-shaped hypergranulosis due to the hypergranulosis being concentrated around the apocrine, the sweat glands and the follicular units. So that's why we call it the wedge-shaped hypergranulosis is basically refers to that. So yeah, these are the features of classic lichen planus. So the next feature we see in the epidermis is the presence of parakeratosis. And parakeratosis, especially when associated with epidermal spongiosis, can be a feature of pityriasis lichenoides. However, remember, this can also be seen in lichen striatus. And the difference between lichen striatus and pityriasis lichenoides is the peri-adnexal environment. All right. So you're seeing here epidermal spongiosis. This is not just basal vacuolation, but you're also seeing epidermal spongiosis. So the presence of spongiosis and parakeratosis often is a sign of pityriasis lichenoides. All right. So the epidermis, what we're looking for in higher power, atrophy, presence of acanthosis, pseudo-epidermatous hyperplasia, often seen in hypertrophic LP, but also in mucosal LP, hypergranulosis. And hypergranulosis, however, is not a specific feature. Please don't look at it and try to narrow down your diagnosis because hypergranulosis may or may not be present in lichen planus. Then parakeratosis, as I said. Now, parakeratosis often is associated with spongiosis. And so look at that association. But presence of parakeratosis alone does not mean anything. It could be secondary also. For example, in cases of mucosal or especially vulval lichen sclerosis or lichen planus, presence of parakeratosis could just mean secondary candidal infection. So please do a PA stain if you are seeing parakeratosis in the setting of a mucosal lesion. All right. Now, the next feature, as I said, is spongiosis. Then the next feature is epidermal cell necrosis. So not only basal cell degeneration, but epidermal cell necrosis, if it's whether it's satellite or focal necrosis, or whether it's frank necrosis throughout the epidermis, as in erythema multiforme TEM. So I'd like to just discuss this interesting case here at this juncture. This is low power view of a patient. You might want to think about the possible differential diagnosis. I'll tell you that this lesion is from the lip. So you might want to try and evaluate this histological slide and see if you can make a diagnosis. There is definitely acanthosis and a bit of pseudo-epitheliomatous hyperplasia. This is from the lip. Clearly lichenoid infiltrate, okay, and concentrate on the basal layers. You're seeing marked spongiosis. Remember, all mucosal interface dermatoses can have spongiosis because of coexistent inflammation, and this is usually a feature of all mucosal lesions of lichen planus, etc. So see if you can make a diagnosis. Marked epidermal spongiosis, and you can see a diskeratotic cell here. Then you go another section, look at this mitotic figure, beauty. So mucosal lesions can be quite tricky to diagnose actually. You're seeing a few eosinophils also here, probably incidental. And there was a mitotic figure here, see, look at this mitotic figure, look at this sort of atypical cell here. You see the epidermal cells appear atypical. There is a slight loss of polarity also, okay? So, but it's not, is this enough to call this anything? This is a lip lesion. Anybody wants to type in your answers in the chat box before I show you the clinical picture? Any answers in the chat box, madam?
So far, no answers, sir.
No answers.
Receive any.
Audience are stunned to silence. Okay, this is a clinical picture. This is a man, about 60-year-old, who had a tumor in the cheek of unknown, I don't know what the tumor is. He had this excised and grafted many years ago, now presented with a 2-year history of this plaque on the lip. So when I first reviewed the histology, I thought this was actually hypertrophic LP with the disc keratosis being reactive. However, having said that, I treated him with interlesional steroids and the lesion did not budge at all. So eventually I had to, change my mind and make the diagnosis as in situ SCC. So this lip lesions, lip lichen planus, can be extremely difficult because there is often associated disc keratosis, and disc keratosis could be just due to the inflammation because lip lesions tend to be very inflamed. Disc keratosis is present, and not only disc keratosis, dysplasia is present, and dysplasia can be subtle, very subtle. If the dysplasia is really intense throughout the epidermis, then you got an easy diagnosis, but sometimes it can be very difficult. So the next thing you evaluate in higher power is the presence of epidermal dysplasia. Okay, so dysplasia refers to malignant change. Disc keratosis refers to dyspaturation. So please make a distinction. This is a case of oral lichen planus, and look at the amount of dysplasia here. There is dysplasia, but it is basal. The top layers are relatively okay, but it is a very difficult case. This is a case of oral LP, responded well to oral steroids. But look at the huge atypical nuclei here of these cells. And this is more atypical than the case I called as in situ SCC. So lip lesions is very tricky. Be very careful. Always correlate clinically. All right. So the next feature we evaluate on higher power is the basal membrane. Whether and as a rule, basal membrane is either destroyed or fragmented in most interface dermatoses. Okay. And this is because the intense inflammation destroys it. Now, having said that, remember that the epidermal basal membrane is always trying to regenerate itself. So in some chronic inflammatory dermatoses, when the epidermal basal membrane is destroyed, the regenerative process tends to be excessive and produces thickening of the basal membrane. Usually in these cases, the inflammation is very sparse. So you don't see epidermal basal membrane thickening where the inflammation is intense. You see it in chronic cases where there is chronic stimulation of the basal membrane by few lymphocytes leading to thickening of the basal membrane without much destruction. So it's always a balance. The basal membrane is being destroyed and rebuilt. If destruction becomes small, then you don't see the basal membrane. If the destruction becomes less and the regeneration becomes more, you see reactive thickening. You see this usually classically in discoid lupus erythematosus, but also described in dermatomyositis and lichen sclerosis. And this is an example of DLE with basal membrane thickening. Okay. Then we're coming to the dermal features. We finished the epidermal features, we finished the basal membrane features. Now we're coming to the dermal features. Now I've already discussed the nature of the infiltrate, whether it's lichenoid or vacuolar. And then we've also described the distribution of infiltrate, the lichenoid infiltrate, whether it's just touching the basal membrane as in lichen planus or early lichen sclerosis, or sometimes it can be lichenoid, or it's obscuring the dermo-epidermal junction. Technique called as true interface dermatosis because it is spanning the interface, this side and that side. So these are erythema multiforme, fixed drug eruption, pleva, etc. So then we're looking at the type of cells. And the type of cells, lymphocytes obviously predominate in interface dermatosis. However, if there are histiocytes, think about lichenitis, but also remember papillary GA, papillary sarcoidosis, and lichen sclerosus can also have interface change and histiocytes. So these are differentials. Now, this is an interesting case. This is an infective condition. I don't know if anybody can make the diagnosis. This is an infective condition which classically presents as a granulomatous infiltrate. You can see here, sorry, the sections are not that great in this particular slide. I was in a hurry and I couldn't find a good slide, but you're seeing vacuolar interface change associated with lymphohistiocytic infiltrate and giant cells also. Anybody who wants to give out the answer in the chat box? Or maybe you're bored of giving answers. Anybody? Examples of lichenoid and granulomatous infiltrate, apart from what we've discussed already.
We have got a response as scabies, sir.
Scabies, okay. I don't know whether seeing the scabies might actually. No, this is not scabies. This is actually, in fact, Hansen's. This is a case of borderline Hansen's. And I put this particular example because in Hansen's, the interface dermatitis, in my experience, is what is responsible for the hypopigmentation you see in these lesions. So often look at your case of borderline Hansen's, especially borderline, either usually tuberculoid spectrum or even borderline. You often see these, vacuolar, you see a vacuolar interface change along the interface. So this is an example of Hansen's with vacuolar interface change. So the lichenoid granulomatous pattern, however, technically, traditionally is described in lupus vulgaris, deep fungal infections, granulomatous secondary syphilis, and drug eruptions. But Hansen's is a very important thing to also remember. All right. So looking at type of cells, we looked at lymphocytes with histiocytes, then lymphocytes with neutrophils and eosinophils, drug reactions, predominant plasma cells seen in syphilis, ectodermatitis, chronica atropicans. The next thing we look for in the type of cells is this. Anybody know the answer to this? What is the diagnosis here? This is a classical textbook picture. I don't even need to describe it. Anybody can give out the diagnosis without me giving you any history or any other description? Anybody, Dr. Venkat, has typed the answer?
Not yet, sir.
Not yet. Okay, give about 5 seconds more. So what you're seeing here is confluent vacuolar interface change. Okay.
Someone has written.
Yes.
Mycosis fungoides.
Yes. So this is mycosis fungoides. You're seeing epidermotropism of lymphocytes forming even small portraits, microabscesses here. And so the next feature you look for is atypical lymphocytes. Obviously, I mean, lymphocyte ATPia is in the eyes of the beholder in the early cases, but this is something you need to look for. So this is an example of an interface dermatitis, which is not a dermatitis, it's actually a malignancy. Then if you're seeing interstitial infiltrates composed of lymphocytes, histiocytes, eosinophils, and neutrophils, then your diagnosis, granulomatous dermatitis or palisading neutrophilic and granulomatous dermatitis or interstitial granulomatous dermatitis, as it's also called. Both are overlapping entities. Then the other dermal feature we look for is the presence of melanophages and pigment incontinence. This can be very prominent, and if it is prominent, then you think of two diagnoses. I have a quiz here. Perhaps I'll go to the quiz first. Maybe not. Okay. Maybe the quiz have taken it out. Okay, fine, no problem. So sometimes pigment incontinence is maybe the only feature that is seen. There may not be any infiltrate at all. And this can be the only clue to the diagnosis of the presence of lichen planus, presence of interface dermatitis, especially in the late stages where the inflammation is gone. So this is called post-inflammatory change, where you see effacement of the retiridges. The retiridges are completely gone. Okay, and then there is chromatization of the basal layer. The basal cells do not no longer appear cuboidal, do not appear columnar. They appear cuboidal, as if the spinous layer is sitting directly on the basal membrane. So this is called squamatization of the basal layer, effacement of the retiridges. So, these are features of post-inflammatory change, and you should still be able to make a diagnosis of post-inflammatory interface dermatitis. For example, lichen planus pigmentosus in the late stages can show features like this. So dermal features, melanin incontinence, as I've already said, and sometimes this may be the only feature associated with melanophages. Look at this case. This is another case of the same thing. You're seeing colloid bodies as well. This is lichen planus pigmentosus with pigment incontinence. All right, here's a quiz. One can determine the clinical color of the lesion based on the presence or absence of melanin incontinence. True or false? Please type T for true, F for false. One can determine the clinical color of the lesion based on the presence or absence of melanin incontinence. First answer, please, Dr. Venkat, since we're short of time.
False. Majority of it have answered false, sir.
Excellent. It is false because case of lichen sclerosis, a so-called white depigmenting disease, can have a lot of melanin incontinence, and case of lichen planus may not show much melanin incontinence in the early phases. So one may not be able to, though clinically the lesion is quite violaceous. So presence of melanin incontinence alone does not determine clinical color, atrophy of the epidermis, hypertrophy of the epidermal thickness, the Tyndall effect, the presence of the thickness of the dermis itself. These are all determining factors. So next thing we look at in the dermis is this, the vasculature. Now this particular feature, lymphocytic cuffing around the capillaries, is a feature usually seen in a number of interface dermatoses, including pityriasis lichenoidis, lichenoid purpura, lupus, and drugs. So look at the vascular changes, but these are usually the superficial and deep infiltrates. So this comes in the low part itself. You've noticed that there's superficial and deep infiltrate, and then you've seen perivascular cuffing. Then you narrow down the differentials to these four. Often you may not see much of an infiltrate in a place where there's a lot of solar elastosis, basal vacuolar damage, epidermal atrophy. You're seeing a few dilated capillaries. Okay, so this is another case. Similar, same diagnosis. You're seeing a few dilated capillaries, basal interface change. Then your diagnosis is poikiloderma. So telangiectasia is one more vascular feature to look for apart from perivascular lymphocytic cuffing. Some people call this lymphocytic vasculitis. So though this is a very controversial term, I won't go into this. Then the other dermal feature we look for is the presence of this sort of fragmented collagen, which seems to be separated apart. And if you look closely, you're seeing this sort of bluish strands between the collagen, which is basically mucin. So presence of dermal mucin is a clue to the presence of the diagnosis of lupus. So this is the other dermal feature we see. This is the next dermal feature that we may see. In this case, you're seeing a lot of epidermal hyperkeratosis. This is not the feature I'm looking for, but look at the dermis. Here, this is definitely lichenoid interface dermatitis. You're seeing a perifollicular infiltrate associated with dilated infundibulum follicle. And look at the dermis here. Anybody wants to make a diagnosis? The next dermal feature that we look for. Type it in your chart box, please. You can either just type the diagnosis directly. The first answer, Dr. Venkat.
So far, no one has written yet to receive the answer.
Yes. It's an easy diagnosis. Probably the presence of interface dermatitis, the presence of lichenoid infiltrate is what is confusing you here. All right, I'll give out the answer. It's a classical case of morphia.
Morphia, yeah. It's now
You're seeing loss of appendages. The morphia can have lichenoid interface change. And that is the reason I put this case here. So presence of scarring is the next dermal feature you look for. Okay. So just because you're seeing an interface dermatitis, please do not exclude the diagnosis of morphia. Morphia can have interface change in a number of cases. So presence of scarring is the next feature we look for. The last feature is looking at the panicculum. If you're looking at a lobular panicculitis, think about lupus. If you're looking at a septal panicculitis, in association with other features, of course, then think of morphia. But yes, you don't make a diagnosis based on the presence of panicculitis and morphia. It's usually an associated finding. Okay. So the last few slides deal with the lichenoid infiltrate, which is not a dermatitis. I've already discussed one case with you before. This is another case. It's a lichenoid infiltrate, not a dermatitis. Anybody wants to give out the answer? It's an easy low power diagnosis. This is lichenoid infiltrate, not a dermatitis. The first one we discussed earlier is mycosis fungoides, which is a lichenoid infiltrate, not a dermatitis. Anybody? Look at the epidermis here. There is a sharp cutoff. Here the basal cell does not appear pigmented. Here it appears quite markedly pigmented. Slight elongation of the retiridges. Not much atypia, no parakeratosis, slight acanthosis. No, this is a case of solar lenticum with associated lichenoid change. So lichenoid change can accompany both benign and malignant epidermal tumors, including melanoma, basal cell carcinoma, squamous cell carcinoma. So just because you're seeing a lichenoid infiltrate, do not classify it as an interface dermatitis. As a dermatitis, look for the associated changes. As I said, the lichenoid interface share should be primary, it should not be secondary. That's the second feature we look for when we are looking at evaluating dermatoses. So this is we've discussed before, like mycosis fungoides. Then remember, anybody know the diagnosis to this? Clear-cut diagnosis? I don't need to explain this. Anyone? The lichenoid infiltrate here is not much prominent, but this is a good example of this particular case. So I put this slide. I'm hoping everybody would have got the diagnosis.
Someone has written Bowen's.
No, this is a classic coronoid lamella. Porokeratosis. Okay. So porokeratosis, often there is an associated lichenoid infiltrate, degenerate diskeratotic keratinocytes here at the bottom, and there's often a lichenoid infiltrate at the bottom here. Lichenoid infiltrate can extend throughout the specimen also, even in the places where there is no coronoid lamella. So remember that this is again not, I mean, this is a controversial entity, whether it's actually a tumorous thing or it's actually inflammatory dermatosis, but yeah. Okay. So in summary, we'll come to the last few slides. How do I evaluate interface dermatosis? Ascertain the presence of epidermal basal damage, that is primary. Then whether it is a primary interface dermatosis, and also whether the interface change is primary, look at that. And whether it's secondary interface dermatosis, secondary to another condition. Evaluate on low power, look at the intensity inflammation, distribution, whether it's superficial, pansection, focal, deep, superficial and deep, interstitial, panicular involvement, adnexal involvement, look at these factors. Then go on to higher power, look at the epidermis, atrophy, hypertrophy, ortho, parakeratosis, focal or diffuse, then hypergranulose or not, spongiosis or not, type of keratinocyte degeneration, is it vacuolar or filamentous, basal versus pan-epidermal keratinocyte degeneration, presence of dysplastic changes, epidermal tropism of atypical lymphocytes, and then look at the base membrane. Is it thickened or destroyed? Then look at the dermis, nature of the infiltrate. Is it lymphocytes alone or the presence of other cells? Degree of pigment incontinence often can give you a clue to the diagnosis of lichen planus pigmentosus or fixed drug eruptions. Vascular changes, true vasculitis versus perivascular lymphocytic cuffing, telangiectasia, interstitial mucin, and the presence of scarring. I mentioned the morphia earlier as an example of scarring, but yes, if there is just superficial scarring, think of lichen sclerosis. If it's periadnexal scarring, even in the absence of inflammation, think about lichen planopilaris. Okay, pandermal scarring is morphia or scleroderma. I'll leave you with one last case. This is the last case I'm going to discuss. Now, classical example of what you would call a lichenoid infiltrate. In this, you're seeing wedge-shaped hypergranulosis, band-like infiltrate, sawtoothing of wetty ridges here, okay? Hypergranulosis, wedge-shaped hypergranulosis, colloid Civatte bodies, classical case of lichen planus, no doubt. Look at this clinical picture. Patient has depigmented patches in what you would typically call as areas of vitiligo. Clinically, this is vitiligo. Just there is mild scale on top. Look at these patches. Look at these patches in the legs, vitiligo. Look at this patch in the chest, vitiligo. Case of vitiligo that histologically has got features of classic lichen planus. Okay, so inflammatory vitiligo, or in case of vitiligo on photoexposed sites, sometimes we might see secondary lichenoid changes, what people have referred to as vitiligoid DLE sometimes. We don't know the exact answer to that, but this is not unheard of. Actinic lichen planus usually is hyperpigmented rather than hypopigmented. Okay, so these are the differentials in this case, but the take-home message is that all that glitters isn't gold. Just because you're seeing a lichenoid infiltrate that is classical of lichen planus, do not make the diagnosis without clinical pathological correlation. It's almost impossible to make a definitive diagnosis of interface dermatosis without clinical correlation, because the same histological picture may be shared across multiple pathologies. And the pathological picture varies even within the same patient, depending on the stage of the lesion, site of biopsy, and prior treatment. I thank you very much for this opportunity and your patient listening. And I hope if you have any further questions, I'll be more than happy to answer. And also, yes, I just want to leave you with this. I have a DermPath WhatsApp group, which we intermittently tend to discuss interesting DermPath cases. So if you're interested, please ping me on my mobile number and I'll be happy to join you in the group. Thank you very much.
Now the forum is open for any questions. If you want to ask any questions, please unmute yourself and ask questions, or you can drop the questions in the chat box. I shall read it for Dr. Sashikiran. Okay, so if there are no any questions, so okay, thank you, sir. Thank you for a wonderful and interesting session on lichenoid dermatitis. It was very interactive, and we had got very good interactive responses also on the chat box. So everyone have enjoyed it.
It was a very, very informative and interactive session. That was the best part of it. It was like a conversation and one-to-one. So we really enjoyed your session. Thank you so much. And
Thank
the
you, ma'am.
pictures
Thanks a
were,
lot.
yeah, it was very clear. The pictures were very good. Thanks a lot for
Thank
your.
you, ma'am. Thank you, ma'am. And just to mention, people who want to do a bit more reading, there is a recent review article on interface dermatosis I've written in the Indian Journal of Dermatopathology. That's available for free on the web. So please feel free to access it.
Sure. Thank you so much.
Thank you, ma'am. Thanks a lot.
Thank you, sir. Next session is on histiocytic disorders of bone marrow, a diagnostic challenge by Dr. Shubhangi Agale. Welcome, Dr. Shubhangi Agale, madam. Am I audible, ma'am? Shubhangi, ma'am?
Welcome, madam. Please unmute yourself, madam.
Yeah. Thank you very much.
Yeah, I shall just introduce you to the forum, madam. Then you can.
Yeah, I will share my screen.
I make you the co-host. Yeah, I made you the co-host, ma'am. Meanwhile, I shall introduce you to the forum. Dr. Shubhangi Agale had done her post-graduation in pathology from Tata Memorial Hospital, Mumbai. A very sincere and an ardent teacher, and at the same time, very humble and down-to-earth person. She is the president of Maharashtra Association of Pathologists. She has contributed 2 chapters to Hematology Book 2012 and has many international and national publications to her credit. In addition, she is on the editorial board of IJPM, IJPRB, etc. She has delivered various guest lectures in international and national conferences and has organized conferences and CMEs. Currently, she is working at Grand Government Medical College in Sir JJ Group of Hospitals, Mumbai. And the one very interesting feature about this hospital is they are experts in hosting autopsy workshops. That's how I could meet madam. Now she's here with us, allocating her precious time during this festival to deliver a talk on histiocytic disorders of bone marrow, a diagnostic challenge. Madam, the session is all yours now.
Thank you. Thank you. Am I audible?
Yes, madam.
Okay. I have shared my screen with you. Is it visible?
Not yet, madam.
Okay. Sure. Okay. So this is the webcam, no? Share screen. Desktop. Should I go to desktop?
Here is your presentation, ma'am. It is
Desktop.
Then you have to go to desktop, madam.
Okay.
If you have minimized your presentation, the minimized thing will be shown. Or if it is the desktop, you just have to go to desktop and click on the presentation.
Okay. I will minimize your.
Or before share screen, you can just go to the presentation and minimize it, madam. Then you can press the share screen button and then click on the presentation.
Yeah, I have opened it.
Minimize the presentation, madam. Minimize the PPT and now come back to the Zoom, madam. And then click the green button, share screen. Yes.
Yeah.
It is processing. Yes. Now we can see the screen. Yes, madam.
Yeah. Thank you. Thank you very much. Thank you, everyone. I am Dr. Shubhangi Agale. I am from Grand Government Medical College. I will be speaking on histiocytic disorders of the bone marrow, a diagnostic challenge. At the outset, let me thank Dr. Soumya Madam, who is HOD of the pathology department, and Dr. Venkat, who has been coordinator for this CME. The histiocyte is a part of mononuclear phagocyte system. It is a tissue macrophage which deals with host defense and tissue repair. It is usually derived from the blood monocyte, which gives rise to this macrophage, and from this macrophage, we have the histiocytes which are present in the connective tissue. We have other macrophage cells in the organs, in the parenchymal organs from this macrophage, but we will be dealing with the histiocytes mainly. So I will be speaking of histiocytic disorders of the bone marrow. The histiocyte is usually CD14 positive, CD68 positive, and CD113 positive, and CD11 positive. This immunoprofile or immunophenotype differentiates it from other cells such as Langerhans cells and dendritic cells, which we have to keep in mind because they also come in the histiocytic disorders. Now, oh God, what is this? I'm sorry, I think.
And your screen
These
is visible.
histiocytes.
Yes.
Am I visible?
Yes, ma'am, it is visible.
Yeah. Thank you. These histiocytes are dispersed throughout the bone marrow. They are usually located in the hemopoietic islands in the bone marrow. These are the histiocytes which are stained by CD68 immunostain, and they are positive for CD68, and these are seen in the hemopoietic islands, that is erythropoietic islands in the bone marrow. This is a fatty marrow, and they are inconspicuous unless they are increased in number, they are enlarged in size, or they have disturbed location, means they are opposite the bony trabeculae or elsewhere, and their cytoplasm is altered due to phagocytosis. Under these four conditions, the histiocytes will be greatly visible to us, and then we can diagnose them as histiocytic disorders of the bone marrow. Now, the histiocytic disorders of the bone marrow, which I am going to describe today, will be different from the histiocytic disorders, which is given by a histiocytic group of people who have classified histiocytic disorders of the body. Those are totally different from the histiocytic disorders of the bone marrow. Some of the histiocytic disorders which are present in the all the bone marrow, that I will be covering. So basically, histiocytic disorders of the bone marrow are mainly divided into two: non-neoplastic disorders of the bone marrow and neoplastic disorders of the bone marrow. Out of these, the neoplastic disorders are many, which we will cover only one of them, and non-neoplastic disorders, I will cover many of the non-neoplastic disorders. In the neoplastic disorders, we have histiocytic sarcoma, then tumors derived from the Langerhans cells, which I will be covering, then indeterminate dendritic cell tumor, interdigitating dendritic cell sarcoma, follicular dendritic cell sarcoma, fibroblastic reticular tumor, disseminated juvenile xanthogranuloma, and Erdem-Chester disease. Now, what to observe to confirm the malignancy in the bone marrow aspirate or biopsy? There are certain characteristics of the disease which you can look into, which will confirm the malignancy. One of them is proliferation composed of atypical cells, then infiltrative and destructive growth pattern of the neoplasm, tumor necrosis if it is present, anisocytosis, anisokaryosis, increased nuclear cytoplasmic ratio, chromatin abnormalities which are present in the form of hyperchromatism, irregular chromatin distribution, chromatin clumps, then hypereosinophilic nucleoli, and brisk or atypical microactivity. All these features you have to look for to confirm the malignancy in cases of bone marrow disorders. And this is the diagram, a photograph which shows you sheets of atypical cells which are infiltrating the marrow and totally destroyed the marrow. There is no hemopoietic tissue or fatty marrow in this diagram. And this is the bony trabeculae which are also destroyed. This is the high power view to show you these are cells large, atypical. They have large nuclea, which that means that high NC ratio. There is hyperchromatism, and there is anisocytosis and anisokaryosis also. This is another picture to show you how the features of malignancy can be seen. This is large nucleus with prominent basophilic to eosinophilic nucleoli, scant cytoplasm, mitotic activity. So all the features of malignancy which we have described just now are visible in this. So it's a malignant neoplasm. So coming to the first of the malignant neoplasm of the bone marrow, Langerhans cell histiocytosis is a new terminology for the disease which was initially known as eosinophilic granuloma. It is a single lesion of bone, lymph node, or skin. The second variety is Hand-Schuller-Christian disease, which is comprised of lytic lesions of the skull, exophthalmos, and diabetes insipidus. Third category is littoral Civatte disease, where widespread visceral disease involving the liver, spleen, bone marrow, and other sites is present. These are the old terminologies which were used. After that, there was histiocytosis X, the term suggested by S. Faber and proposed by Lichtenstein in 1953. After that, we are using Langerhans cell histiocytosis term, which is a new terminology. A little bit about Langerhans cell histiocytosis. It's a rare hematopoietic neoplasm due to mutations in the MAPK pathway. The Langerhans cell itself is characteristically expresses Langerhans, that is CD201. The Langerhans cells are named after the Paul Langerhans, a German physician. He was an anatomist who at the age of 21 years diagnosed this cell. He was a medical student, and at the age of 21 years, he has diagnosed this cell as Langerhans cell. So the disease is named after him, Langerhans cell histiocytosis. The Langerhans cell histiocytosis is commonly seen in children with an incidence of 5 to 9 cases per 1 million population, whereas in adults it is rare with 1 case per 1 million population. The common sites for the disease are bones, that is 80%, skin is involved in 30% of the cases, pituitary gland in the central nervous system is involved in 25% of the cases, whereas liver, spleen, and bone marrow is involved in 15% of the cases each, with lymph node 10% and central nervous system less than 5%. What is important here is liver, spleen, and bone marrow. These organ involvement has poor prognosis for the disease, and thus these are called high risk organs, and usually when the staging of the disease is done, the biopsies from the liver, spleen, and bone marrow have to be examined to rule out the multisystem disease. Now, as I said, LCH can be a single system disease, that is SSLCH, that is single system Langerhans cell histiocytosis, or it can be a multi-system Langerhans cell histiocytosis, that is MSLCH. Bone marrow involvement is usually associated with multi-system Langerhans cell histiocytosis, and bone marrow examination is usually done to categorize the disease process and to determine the mode of the treatment. And that's why bone marrow examination is very important in the diagnosis and staging of the Langerhans cell histiocytosis. Now, morphologically, Langerhans cell histiocytosis is mainly comprised of Langerhans cells, then followed by eosinophils 92%, multinucleated giant cells, lymphocytes, necrosis, neutrophils, and foamy histiocytes. But in the early stages, you may get Langerhans cells varying from 5 to 75%, and in the late stage also you may get less Langerhans cell due to fibrosis. That you have to keep in mind. When the Langerhans cells are very less, 5 to 75%, the other cells predominate, that is eosinophils, multinucleated giant cells, and lymphocytes. So if you have a combination of these cells, you must look for the Langerhans cells, and you must do immunohistochemistry for the visualization of the Langerhans cells. Now, in the disease process, you may have mild atypia, which is of reactive type in 50% of the cases. So it should not be diagnosed with Langerhans cell sarcoma, because Langerhans cell sarcoma is considered as a histologically malignant counterpart of this. This is also neoplastic disease, LCH. The mitotic rate may vary from 0 to 23 per 10 high power field in LCH itself. This is the bone marrow aspirate from a patient who is young, and he presented with skin rash and bone osteolytic bony lesions. So skin biopsy was done and bone marrow aspirate was carried out. And this is the aspirate from that patient. Now, if you look at the aspirate, it's quite hypercellular aspirate. You are seeing erythroid cells here, group of erythroids, so 4 to 5 cells. Then you have few neutrophils here and there, and few plasma cells, whereas most of the cells here are large cells with pale blue cytoplasm, indistinct cytoplasmic margins somewhere distinct cytoplasmic margins. These are the cells which are present singly scattered here in the bone marrow, and the nuclei of these are oblong to kidney shaped with nuclear grooves here, and some of the nuclear membrane is very irregular. So these are the cells which are present here in the bone marrow. These are Langerhans cells. Grooving confirms the characteristic Langerhans cell. This is the bone marrow biopsy, which is showing sheets of Langerhans cells. These are the cells. In here, we also have many eosinophils, which are scattered throughout, and these are the venules which are present in the section. So these cells are varying in size. There is nuclear pleomorphism little bit, but what is characteristic is that they have moderate amount of cytoplasm, which is eosinophilic, and their nuclei are indented or grooved, and most of the nuclei have irregular nuclear outline. If you do not get the grooves in the cell population, please look for the irregular nuclear outline. That is also characteristic of Langerhans cells. They may be binucleated and they may show nuclear pleomorphism, which is present here like this. The other cells which may be present may be few neutrophils, plasma cells, and few lymphocytes. This case was subjected to immunohistochemistry, and this is a CD1A which is positive, which is characteristically seen here, cytoplasmic positivity in the cells. So this is a Langerhans cell histiocytosis. Now this is a study from North India, and these authors have studied 5 to 6 cases of Langerhans cell histiocytosis involving the bone marrow. And according to them, this is the aspirate. According to them, there are 2 to 3 cells present in the bone marrow in many of the cases of these Langerhans cell histiocytosis on the aspirate. So this is the aspirate from their case, which is showing presence of only 2 to 3 cells in the cluster of hematopoietic cells. This is megakaryocyte, Whereas when the biopsy was done, there were sheets of cells involving the bone marrow. Here, this is low power and this is the high power, which is showing nice histiocytic cells with irregular nuclear membrane present in sheets with few other hematopoietic cells. So these authors have suggested that when you get a aspirate which is showing very few histiocytic-like cells, kindly subject the patients to biopsy, and biopsy should be multiple to rule out the Langerhans cell histiocytosis, because the disease process may be very irregularly distributed throughout the bone marrow. This is the CD1A, which positive, confirming the Langerhans cell histiocytosis. Now, the immunophenotype of Langerhans cells is S100 positive, CD1A positive, which I have shown you, CD207, that is Langerhans positive, and cyclin D1 is usually positive. What is important is that S100, CD1A, and 207, that is Langerhans, are not restricted to Langerhans cells only. They are also positive in other dendritic cells that you have to keep in mind. And because of this, for confirmation of Langerhans cell histiocytosis, we need to do electron microscopy. And this is the electron microscopy of the Langerhans cell. This is the racket-shaped granules which are present in the cytoplasm of the Langerhans cells. These granules are named after the Michael Burbeck, who discovered them in the Langerhans cells, and these are known as Burbeck granules. This is diagnostic of Langerhans cells, and electron microscopy confirms the diagnosis of Langerhans cell histiocytosis. These Langerhans cells, these Burbeck granules, are also known as Langerhans bodies, which are named after the Langerhans. Coming to the genetic abnormalities in the Langerhans cell histiocytosis, 85% of the Langerhans cell histiocytosis cases have genetic abnormalities of the MAPK pathway, and because of this genetic abnormalities, they are associated with other hematological malignancies also. This is very important because in their lifetime, when you do the follow-up, these patients are known to develop other hematologic malignancies, and that should be kept in mind by the clinician and by the pathologist, because recurrence may occur, but other hematological malignancies also are known to occur. How to manage these patients? These are treated with chemotherapy, vinblastine, and steroids. Prognosis is usually poor in multi-system Langerhans cell histiocytosis, where the bone marrow is involved, whereas in single system involvement, the prognosis is slightly better. The follow-up of the cases is essential, as I said you, because hematological malignancies are known to develop in these patients. Now, coming to the non-neoplastic histiocytic disorders of the bone marrow, we have many of them which I will go through, but main histiocytic disorders which are non-neoplastic are hemophagocytic lymphohistiocytosis, storage disorders, granulomas, and sea blue histiocytosis. These are the main disorders which I will cover throughout my lecture. Coming to the case 1, a 35-year-old immunocompetent male presented with fever and weight loss of 1 month duration. He also had diarrhea and loss of appetite since 12 days. There was no history of tuberculosis, diabetes, or hypertension. On general examination, he was febrile, pallor was present, pulse rate was 108 per minute, BP was low, respiratory rate was 16 per minute, but he had no lymphadenopathy or jaundice. On systemic examination, his CVS, RS, and CNS was normal, but he had hepatosplenomegaly, that was the positive finding. Also, his investigation showed that he had pancytopenia, his triglycerides were raised, his ferritin level was raised, and his LDH was raised. So all these parameters were raised in this patient. This is the peripheral smear of the patient, which is showing microcytes and target cells, and there is decreased leukocytes and platelets on the peripheral smear, so pancytopenia. And this is the bone marrow aspirate. Any guesses for this bone marrow aspirate? What are these large cells? Okay. This is the bone marrow aspirate, which is very hypercellular, and these are the erythroid cells, few of them which are present here, few myeloid cells, and there are large cells here present in clusters and singly scattered. I will go to the high power view. This is the high power view to show you these large cells. These are the large cells which are present in clusters and singly scattered in the bone marrow. All these large cells have slightly eccentric nuclei, and their cytoplasm is filled with these lymphocytes and erythroid cells. Here also, here neutrophilic cells also are present, erythroid cells. So cytoplasm is full of these cells in the bone marrow. This is another view to show you that there is phagocytosis of the RBCs also and erythroid cells also. This is the central nucleus of the histiocyte, and this is the erythroid cells, and these are the RBCs which are phagocytosed. Here also, this is the nucleus of the cell, and these are the phagocytosed nuclei or cells in the cytoplasm of the cells. So the differential diagnosis on cytology, bone marrow aspirate, is HLH or Rosai-Dorfman disease. But in Rosai-Dorfman disease, we get phagocytosis of the lymphocytes only. We do not get phagocytosis of the erythroid cells or RBCs is absent in the Rosai-Dorfman disease. So we would like to favor HLH. Of course, we will see further how to confirm HLH in this case. And this is the bone marrow biopsy which was carried out. You have these clusters of histiocytic cells here in the bone marrow. But in the background, in the stoma, you can see this eosinophilic material, which is a fibrinoid necrosis of the stoma, which is characteristically seen in the HLH. So this one more feature which is favoring the HLH over the Rosai-Dorfman disease. So coming to the criteria for the diagnosis of the HLH, these are the modified criteria. First criteria, you must have a molecular diagnosis of HLH. If it is there, molecular diagnosis, it's confirmed, so it's very good. But if you do not have a molecular diagnosis, you must have at least 3 of the following, that is out of fever, splenomegaly, and cytopenias, minimum 2 cell lines reduced, and hepatitis. Out of 4, you must have 3 present in the patient. And lastly, and at least 1 of the 4, that is hemophagocytosis, increased ferritin, increased soluble interleukin-2, and absent of very decreased natural killer cell function. Now, what is important is that you have to remember that according to these criteria, one can establish a diagnosis of HLH without morphologic evidence in the bone marrow or in the lymph node also. That you have to keep in mind, because one of the criteria is hemophagocytosis, and it may not be seen in the marrow, and other may be seen, and that time you can diagnose this case as HLH. So morphological diagnosis of hemophagocytosis may be present or may not be present. These are the previous criteria, 8 criteria, which were given in 2007. These were modified to previous one. These are the criteria, that 8 criteria, out of which 5 were required to establish the diagnosis. But now we need 4 criteria for the diagnosis of HLH according to the modified criteria. This is the peripheral smear of the patient, of our patient case which I presented you. It had a falciparum. These are the rings which are present in the RBCs, and some of the rings had 2 dots, which confirm the falciparum infection. So our patient had fever, pancytopenia, hepatosplenomegaly, hemophagocytosis, lymphophagocytosis, increased triglycerides, increased ferritin, and raised LDL. So confirming the diagnosis of HLH. So the diagnosis in this case is hemophagocytic lymphohistiocytosis associated with Plasmodium falciparum. This is the case which is published in Hematology International Journal. This is our case. But HLH secondary to Plasmodium falciparum infection was first reported by Anwar et al. In 1995 in young male, and only 14 to 15 cases of HLH secondary to falciparum are reported till now. Ours is a 16th or 17th case. So coming to the hemophagocytic lymphohistiocytosis, it's a life-threatening condition characterized by severe hyperinflammation. The severe hyperinflammation is due to uncontrolled proliferation of the activated histiocytes and lymphocytes, which secrete large amounts of cytokines. The first case of HLH was reported by Farhouar and Clayraux in 1952, and it was reported as familial hemophagocytic reticulosis. In adults, HLH is often under-recognized because it is not common in adults, it is common in children, but this was case in adult. Coming to the different types of the HLH, you have a primary HLH and a secondary HLH. Of the primary HLH, you have 2 types, familial hemophagocytic lymphohistiocytosis and HLH associated with the immune deficiency syndromes. In the secondary, you have infection-associated hemophagocytic syndrome. The infection may be bacterial, viral, protozoal, and these infections may cause secondary HLH. You have secondary HLH also associated with malignancies such as lymphomas, T-cell leukemias, and other lymphomas, sporadic HLH, then macrophage activation syndrome, and HLH associated with drugs and immunosuppression. So, coming to the primary HLH, the primary HLH commonly seen in young children, and the incidence is 1 in 50,000 to 1 lakh live births. It is a Mendelian inheritance for many of these disorders, and the median survival is 2 months without treatment. The treatment for primary HLH is usually etoposide, dexamethasone, and intrathecal methotrexate or allogenic stem cell transplantation. Secondary HLH is commonly seen in adults, and the malignant neoplasm are usually hematological malignancies, and the infections which cause HLH are usually viral infections. The mortality rate is usually 80%, and therapy is either treat the neoplasm or infection and suppress immune activation by using the steroids. HLH can be rapidly fatal, and for this fatality, hypocytokinemia is considered as a positive factors recently. Coming to the storage disorder, which I will be discussing as a non-neoplastic disorders of the bone marrow. These storage disorders mainly, which I will be discussing, will be of 3 types. The first one is Gaucher's disease, which is an autosomal recessive disorder leading to accumulation of polyps in the histiocytes. The second is Niemann-Pick diseases, which are inherited disorders related to fat metabolism. And third is mucopolysaccharidosis, which is due to disturbances in the normal breakdown of the complex carbohydrates. These storage disorders usually present with cytopenias. The cytopenia is usually due to hypersplenism or encroachment of the histiocytic cells on the bone marrow in the body. They also can produce tumor-like masses in the hematopoietic organs, and they also have inclusions in the blood leukocytes in some of the conditions. Not all, but few of the conditions may produce inclusions in the blood leukocytes and may be diagnosed based on the peripheral smear examination. Coming to the Gaucher disease, which is the most common type of lysosomal disorder, it is caused due to defect in the gene GBA1. The defect in GBA1 leads to deficiency of the glucocerebrosidase enzyme, which is important in the metabolism of the glucocerebrosides in the cells. This enzyme is present in the lysosome, and that is why all these disorders are also known as lysosomal disorders. The types which you have is type 1, type 2, and type 3. The type 1 is a non-neuronopathic disease which is commonly seen in adults without neuronal symptoms. That's why the patient is able to survive till adulthood. Acute neuronopathic type is commonly seen in infants, so usually death occurs during the infantile period. These patients are not able to survive long. And type 3 is subacute neuronopathic, that is commonly seen in children and adolescents. This is the bone marrow aspirate from a patient who was 30 years old, adult patient, came with hepatosplenomegaly, and so was advised hepatosplenomegaly and pancytopenia, and so he was advised to undergo bone marrow aspiration and biopsy investigation. This is the aspirate which is showing this is a megakaryocyte, which is hypolobated megakaryocyte. These are the erythroid clusters. You have few myeloid cells here, and then you have these large cells in the bone marrow aspirate which are present. These are the large histiocytic cells with round to oval nuclei, abundant cytoplasm, and the cytoplasm is very peculiar, which can be appreciated in the high power view. This is the cytoplasm which has a tissue wrinkle paper appearance. And this is very peculiar of Gaucher cells. Tissue wrinkle paper appearance. Wrinkled tissue paper appearance, which is very characteristic of the Gaucher cells. You can see the biopsy. In the biopsy, you have small clusters of cells, pale histiocytes, or sheets of the cells which are involving the bone marrow. This is the bone carefully with complete wipeout of the bone marrow, normal hematopoietic and fatty marrow. So extensively involve bone marrow. This is the high power view to show you that these cells are very large with abundant cytoplasm, which is eosinophilic, and these round to oval nuclei, and there are also multinucleated giant cells. And these are binucleate and multinucleate giant cells. Some of the hemopoietic marrow can be seen here. These are the Gaucher cells which are seen on bone marrow biopsy. These can be confirmed by doing PAS stain, which will visualize the cells very prominently and give positivity to the cell cytoplasm. This is the substance which is accumulated in the cells which comes positive with PAS. The accumulated substance is due to deficiency of glucocerebrosidase enzyme, and these are the glucocerebrosides which are present in the cells. This is yes. Any question? Okay. This is a bone marrow aspirate. These Gaucher cells have to be differentiated from other cells in the bone marrow. And this is a bone marrow aspirate from a younger patient who presented with hepatosplenomegaly and pancytopenia. And these are the only two cells which are present in the bone marrow. This one cell and this is another cell. The rest of the bone marrow is very normal. You know, this is one cell which is present here and another cell. So very sparse cells in the bone marrow, one or two or occasional cell in the bone marrow. This is under high power to show you that this is a one cell which is present in the bone marrow. This is a large histiocytic cell, very vacuolated cytoplasm, and it is totally different from the Gaucher cells where you have a wrinkled tissue paper appearance. This has a vacuolated cytoplasm. These are the myeloid series cells which are present, and this is a erythroid series cell. So these cells are totally different from the Gaucher cells, but they can be seen in the bone marrow. So you should be able to differentiate between the two. The morphology of the Gaucher cell is wrinkled tissue paper appearance, whereas here you have a vacuolated cells. The splenectomy was done in this patient because the cells were very few in the bone marrow, aspirate and biopsy. So to confirm the diagnosis of a storage disorder, splenectomy was carried out. And these are the sheets of cells which are present in the spleen. So the diagnosis which was given was Niemann-Pick disease. The Niemann-Pick disease is characteristically due to mutations in the SMPD1 gene, which leads to shortage sphingomyelinase enzyme in the body, and so there is accumulation of the sphingomyelin in these cells. This is type A, which is commonly present in the infants, and type B, which is commonly present in the children. Mutations in either NPC1 or NPC2 gene will lead to type C, that is C1 and C2, which is commonly present in children and adults. It is also known as lipid histiocytosis because there is accumulation of lipid in the histiocytes, or it is also known as neuronal lipidosis. But what is important to notice, there is no treatment for Niemann-Pick disease. That is very important. There is no treatment. This is the peripheral smear from another patient who was an adult, 25 years, who came with hepatosplenomegaly, but he did not have other joint deformities. He also had joint deformities apart from the hepatosplenomegaly. So his peripheral smear was done, and this is the peripheral smear which shows a large monocytic-like cell with these inclusions in the cell. This is a lymphocyte which is showing inclusion-like purplish granules in the cytoplasm. So the bone marrow aspirate was carried out, and these bone marrow aspirate showed large cells with these granules in the cells. So this is the case of mucopolysaccharidosis due to accumulation of the glycosaminoglycan in the cells. These granules or these inclusion-like things are the substance which is accumulated in the cells. Mucopolysaccharidosis are rare genetic disorders of glycosaminoglycan catabolism due to deficiency of lysosomal enzymes. There is accumulation of GAG in the organs such as skeletal, joint, airways, and other parenchymal organs, and bone marrow may be involved. There is elevation of GAG fragments in urine, blood, and CSF. The MPS is MPS1, which is a Hurler syndrome, which is common in mucopolysaccharidosis, and MPS2, Hunter syndrome. These are the common two syndromes which are seen in the population. The other syndromes are rare. We have many of them and with many subtypes. But these two are the common syndrome, that is Hurler syndrome and Hunter syndrome. The treatment in mucopolysaccharidosis, you can do hematopoietic stem cell transplantation, or recombinant enzyme replacement therapy is available for 1, 2, and type 6 of mucopolysaccharidosis. This is important. That is why it is important to differentiate Gaucher from Niemann-Pick and from mucopolysaccharidosis, because the enzyme replacement therapies will be different in Gaucher and in mucopolysaccharidosis, but there will be no treatment for the Niemann-Pick disease. Coming to my case 2, this is a 39-year-old man, known case of retroviral disease since 7 years, which is on ART since 5 years. He presented with fever and chills of 1.5 months duration with an insidious onset and gradually progressive. Clinical examination, the pallor was present, but there was no lymphadenopathy or organomegaly. The clinically diagnosed as pyrexia of unknown origin or HIV-induced anemia, and he was thoroughly investigated for the disorder. Hemoglobin was reduced. The WBC count was 13,000 per cubic millimeter, slightly raised. RBC count was 3.5 million. Platelets were normal. Peripheral smear showed dimorphic anemia with neutrophilia and hypersegmented neutrophils, suggestive of megaloblastic anemia. He had bilateral lower lung opacity and also had a lesion in the spleen, but there was no lymphadenopathy anywhere. This is the bone marrow aspirate from the same patient, which revealed hypercellular marrow for his disease, and there was mainly erythroid hyperplasia. The bone marrow biopsy was carried out because marrow was little bit diluted and had a vague appearance. So the bone marrow biopsy was carried out, which is showing a hypercellular marrow along with these pale areas which are distributed throughout the marrow. These are the pale areas which are seen throughout the marrows, which are very characteristic. Under low power, they showed this collection of histiocytes. The rest of the marrow here is normal, fatty marrow and hemopoietic marrow, whereas these are the clusters of the histiocytic cells which are present in the marrow. This is the high power to show you the type of cell. These are the epithelioid cells which are showing oblong to slipper-shaped nuclei and indistinct cytoplasmic margins, and cytoplasm syncytium is formed. Epithelioid cells which are surrounded by the lymphocytes and plasma cells. So they have a cuff of lymphocytes and plasma cells. So this is the epithelioid granuloma which is present in the biopsy. This patient also was HIV positive. So we took more sections to see if there is any caseation necrosis, and we got a caseation necrosis in deeper sections. So AFB was done in this patient, which was positive. So the diagnosis which was established in this case was tuberculosis of the bone marrow in a HIV positive patient. The tuberculosis remains a global problem throughout the world. And according to 2018 Global Tuberculosis Report, there are 10 million people who develop the tuberculosis and died. India also contributes very well to the tuberculosis, which we should not be proud of. We should reduce this burden of TB in India. There are 20 lakh cases in India by 2007. It can be reduced by social awareness, creating social awareness throughout the society. The recent advances for diagnosis of tuberculosis, we have auromin staining, gene expert, and this is very important, interferon gamma release assays, which can be performed in vitro tests. These detect the cell-mediated response to the microorganisms, which can be used for the diagnosis of tuberculosis. So coming to the bone marrow granulomas, this is a very nice study which was carried out by these authors, Sampath Kumar, and they have said that bone marrow examination plays an important role in the diagnosis of tuberculosis and other granulomatous disorders in the bone marrow. The granulomas in the bone marrow is an uncommon finding with 1.4 to 2.4% of the cases, and tuberculosis is the commonest cause of these granulomas. Now, if you consider bone marrow granulomas, the origin of the bone marrow granulomas can be bacterial, such as tuberculosis or Mycobacterium avium intracellular. They can be fungal, histoplasmosis and cryptococcosis. They can be viral, HIV, EBV, and other viruses. The hematological malignancies which are associated with granulomas are Hodgkin's disease and non-Hodgkin's lymphomas. Then you have drug-induced granulomas. If the patient is on chlorpromazine, the patient is known to develop granulomas. Then you have autosomal disorders such as rheumatoid arthritis and cause granulomas in the bone marrow. And also there are lipogranulomas in the bone marrow due to destruction of the fat due to any other reason. So coming to the types of the microscopic types of the granulomas in the body, we can have tuberculoid granulomas. Similarly, in the bone marrow, you can have tuberculoid granulomas. You can have sarcoidal granulomas where there is no cuff of the lymphocytes and other inflammatory cells, and they may show other characteristic inclusions and asteroid bodies. Then you can have xanthogranulomas, which is characteristic of juvenile xanthogranuloma, which is comprised of foamy histiocytes in sheets and two-turn type of giant cells. The juvenile xanthogranulomas are known to involve the bone marrow. That's why it is important. You should be able to differentiate between tuberculoid, sarcoidal, and xanthogranuloma. These granulomas can be seen in the bone marrow and can cause enough destruction to produce pancytopenia. The same condition, tuberculosis, sarcoid, and xanthogranuloma may involve different organs. Tuberculosis may involve lung and lymph node. Sarcoid can involve lymph node and other organs, and xanthogranuloma can involve skin and bone marrow. So multiple systems can be involved in the granulomas. That you have to keep in mind. Coming to the last condition of this talk, sea blue histiocytosis, which is a very rare condition. It can be primary or secondary. The primary is autosomal dominant and it is inherited as a lipemic splenomegaly, which is extremely rare. And secondary is caused by MDS, that is myelodysplastic syndrome, lymphomas, CML, ITP. These can have sea blue histiocytes in the bone marrow. These are secondary types of sea blue histiocytes which are seen in the bone marrow. So secondary type is more common. Secondary sea blue histiocytosis is more common as compared to primary. So whenever you get a sea blue histiocyte in the bone marrow, look for these disorders. That is MDS, lymphomas, CML, ITP, and also sometimes Niemann-Pick disease, which is a primary storage disorder, but it can also show you sea blue histiocytes in the bone marrow. The sea blue histiocyte name is derived from the cytoplasm, which is really sea blue, and this is the nucleus of the cell. And this is the aspirate of the sea blue histiocytosis, which is showing sea blue histiocytes in the bone marrow. Sea blue histiocytes may vary, few in number. You have to be very vigilant to diagnose these cells, sea blue histiocytes, and secondary sea blue histiocytosis is more common. So to summarize, the bone marrow histiocytic disorders are uncommon, but they are known to occur in many patients. The non-neoplastic disorders are more common, but they are also very fatal as neoplastic disorders, and these are very fatal because they can involve multiple systems at the same time. Diagnosis of these disorders is crucial for management of these patients, and common mutations can lead to combination of disorders in LCH and other hemophagocytic syndromes also. So you have to be aware of these mutations, and you should follow up these patients frequently. You are the only person on or who can use your ability. So please, confidence in yourself and use your abilities for the betterment of you and society. Thank you very much, and thank you.
Thank you, ma'am. Now the forum is open for any questions.
Yeah, I'm willing to take questions. Should I lower my PPT or this thing?
Or I shall read out the questions for you, ma'am. If they post questions in the chat box, I shall read out for you. Participants are free to post the questions in the chat box, or you can unmute yourselves and
Yeah.
express your queries.
This. I think they do not have the questions. Okay, no problem. Thank you very much. Thank you.
Very the explanations were very nice, madam. So like it is a learning session, so there was not any question.
Yeah. I like my subject very much. Yeah.
It was
Thank
very
you, madam,
you.
for inviting me. I'm
Hello. Hello. I think so. There are some network issues.
Yeah.
Shubhangi.
Connectivity is disturbed. Yeah.
I think so. Ma'am has left.
Ma'am's connection is lost.
She has signed off. Okay, thank you to all the delegates who have spent their time for making. Pardon?
We'll inform madam. Actually, it was a very, very nice session, and right from the basics to how to diagnose, the approach was all very nicely dealt with. So even though madam could not be like joining us in the end of the session, our heartfelt thanks to madam, and thanks to all the participants also. Please join with us for tomorrow's session also. Same time, 11 o'clock we will start. Dr. Venkat.
So yes, thank you once again. Thank you all for making this event successful, for today's program successful. Hope to see you back again tomorrow at the same time. Thank you all.